Good afternoon, everybody, and we'll start second day of our department activity, scientific day. I would like to welcome Dr. Marwan, Dr. Wael Maleh. I saw him. Yes. And I think we have to start on time because we have live transmission at 2:30. So it's my pleasure to introduce Dr. Marwan. Dr. Marwan is one of the family, of the cardiology department family, and we are happy to see you, Marwan.
Thank you so much, Dr. Nabil. Thanks for the invitation, and congratulations for such a great meeting so far. I've attended some of the lectures yesterday. It was fantastic. So let me share my screen, see if you can see it. All right, can you guys see my screen?
Yes, Marwan. Yeah.
Okay, great. All right, so as I said, it's a pleasure to be here with my original family from Ain Shams University. And today I'm going to talk about an interesting, challenging TAVR case that we did a few months back. So she is an 82-year-old lady. She was admitted to our hospital with a CHF exacerbation. She has multiple comorbidities, including hypertension, hyperlipidemia, and was diagnosed with moderate to severe aortic stenosis about a year ago. She also has significant peripheral arterial disease with bilateral claudications and was planned for some intervention for her iliacs, but that didn't happen before she was admitted to our hospital. On examination, when she came to the hospital, she had bilateral crackles bilaterally, JVD elevated. She was in florid heart failure and definitely a significant murmur for aortic stenosis. She was anemic with platelets of 144,000 and had a GFR of 50. We repeated a transthoracic echocardiogram when she was in the hospital, and her EF was still preserved at 55%, but she had severe aortic stenosis at that time with an area of 0.8 centimeters square. Her risk score for STS was elevated, was 9.2, which indicates she's very high risk for surgical intervention. This is her ECG, atrial sensed ventricular paced rhythm. And this is just a couple of clips from her echocardiogram. As we can see, normal ejection fraction, heavily calcified and restricted leaflets of the aortic valve, a lot of turbulence. More pictures here, as we see, barely opening the aortic valve, and high gradients across. So, we decided to start working her up for TAVR since she's not a surgical candidate, and we got our CT TAVR protocol, and she had annulus of about 400, which, it would usually be a 23 sapien valve. We're predominantly sapien at our institute here. She had decent diameters for her sinuses of Valsalva, but she did have, as we can see here to the right upper picture, significant calcium in the STJ. And also her left main was on the lower side was 8.4. So a little challenging anatomy for the aortic valve annulus. The worst part of her CT TAVR was actually her peripheral arterial disease. So significant calcification bilaterally, we can see here on the right. The iliacs go down to 2.5 millimeters. On the left is 3.6. So definitely not feasible for a transfemoral approach. So that was not feasible. We start looking at another arterial axis. So we have axillary, which we can actually see that they're decent size for both axillaries, but if we can appreciate here significant tortuosity of both the left and the right axillary. And also on the pictures here on the right, we see some sort of a venous artifact, which can sometimes be seen on these CTs. And, it really hinders our ability to make sure that the ostium of these vessels, as we can see for the subclavians here and the axillary, if they are healthy enough to accommodate our E-sheaths. So carotid is the same, severe tortuosity, a lot of venous artifacts. So we had one or two options, either to proceed with getting a repeat CT scan, which wasn't ideal in the presence of her CKD and already low GFR, or evaluate her for transcaval TAVR. So we decided to go for the route of transcaval TAVR, and over the next slides, I'm going to walk you guys through how to select these patients and what we did in our procedure. So, the physiology of aortic cable shunt, when we initially started thinking about it back in 2014, was frightening to a lot of people because of, the idea of you're making a big hole in the aorta and, you're going to bleed to death into the retroperitoneum. But actually what we found is, blood tends to go from the hole in the aorta down to the IVC hole, rather than the retroperitoneum, and that's because the pressure in the retroperitoneum is higher than the IVC pressure. And that was actually the main reason for our rule of thumb in these transcable TAVRs, is that you always want to have either these two holes closed at the same time. So if you have your sheath coming from the IVC to the aorta, it has to go all the way from here to here. Or if you want to pull it outside of the aorta, it has to be all the way back to the IVC. You cannot be having this hole in the aorta open while the IVC is closed, then you'll bleed into the retroperitoneum. How do we select our patients? Multiple criteria, but the major four ones are: we want to have the IVC and the aorta close to each other, so favorable less than 8 millimeter lateral distance. It's okay to have some calcium as long as you can have a calcium spared window in between, the calcium areas in the aorta that you can target as your access site. If you have a porcelain aorta, that's definitely unfavorable. You also want to have the distance between your femoral vein and your aortic entry less than 28 centimeters if you're using an Edwards sheath, or if you're using other different sheaths, you want to have it, at least 7 centimeters less so you can reach and have a good purchase of your sheath inside the aorta. You also want to be a little far down from the iliac, so more than 10 millimeters, and far up from the aortic bifurcation into the iliacs. So looking at her CT, we can see, the two yellow dots here are the iliacs, so we are a good distance down from the iliacs. She had an area in the middle of the calcium here that looks like a good target area. It's across, the cartilage between L2 and L3, almost at the lower border of L3. So we mark that, and we use that anatomical landmark during our procedure. By the way, this is just a urethral catheter. This is not a pigtail in any vessel, so we don't get deceived. This is her 3D, and on a, axial sections here, we can see they're very close to each other, the IVC and the aorta, so very good distance, only 1 millimeter, so very favorable for crossing. And the distance down from the femoral vein to our access site into the aorta is less than 28 centimeters, as I mentioned. So, we put our patients into general anesthesia. We start with doing a, intraoperative transesophageal echocardiogram, confirming our aortic stenosis and annulus size and coronary heights. So as we see here, very limited, restricted aortic valve, a lot of turbulence. And then we start by getting our access, and we usually get the right common femoral vein axis as the axis for crossing down to the aorta. On the other side, on the left, we get a vein axis for a temporary pacemaker, 6 French, and then our left common femoral artery axis will be the axis that we're going to snare the crossing wire from the IVC to the aorta, as well as it's going to be our bailout axis. If there's any disaster in the aorta, we're going to put an endograft from that axis. After we have our axis and we're happy with it, the second step is preparing our crossing system, and our crossing system is basically a telescoping system of 4 things. Number 1 is a guide wire that is a 0.14-inch wire, 300 centimeter long wire. We use here the Stato wire, which is a 20-gram low tip. And then we put it inside a wire converter, which can be a piggy bag here, or even a fine cross microcatheter. And the role of this is to switch it down to an 0.35 system where we can put the braided microcatheter, the stiff microcatheter that will cross into the aorta and carry the stiff wire after that. And we put all these 3 inside either an IM catheter or RDC catheter, renal direct double curve catheter, 6 French or 7 French. It should be short, so we should be able to navigate it and direct ourselves to the access site in the aorta. The distal end of the wire, we connect it to the electrosurgery pencil, which is the cautery that we're going to use, and we put a hemostatic forceps to make sure they are connected to each other. I think the most difficult part of this procedure is actually identifying the landmarks and making sure that your IM catheter or RDC catheter in the IVC is exactly facing your gooseneck snare that you put in the aorta. And by that, we try not to move the table too much. We get a lot of AP and lateral views, as we can see in these two pictures. Make sure that if the wire comes out of the IM and crosses the IVC to the aorta, it will end up inside the snare. So that is the step that takes most of the time. But once we're happy, we energize the end of the wire, 50 or 70 volts, just very small, brief bursts of 2 to 3 seconds until we cross into the aorta. And once we cross into the aorta, we snare it with a snare in the aorta. We pull it down into our GR4 catheter that we have in the aorta, and then we push everything up as we are catching on the wire, all the way up to the aorta. I don't have a picture of the snare catching on the wire here, but we basically feed the wire from the IVC all the way to the descending aorta, and at the same time feed the snare so we don't lose access. And once we have our wire there, we start feeding our telescoping system, the microcatheter, one after the other. As we can see here on the picture to the right, we had a little trouble getting the microcatheter crossing into the aorta. We can see there's a little buckling of the catheters as we're trying to do that. So we actually ended up doing a 2.0 millimeter balloon for the aortic hole to make it a little bigger, and then we're able to cross. And once we have our Brady microcatheter up in the aorta, we put our very stiff wire. We use the Lunderquist wire here as our access site to the aorta. After that, it becomes just a regular TAVR. So we put our wire, we put our sheath, we get pigtail from the contralateral axis to confirm our coplanar view. We put our sapien valve across, confirm that our position is good. And if you guys can remember, I mentioned initially that she has significant calcium in the STG. We can see here a lot of calcium at the side, so and also a low left main. So we're trying to land a little lower with that. Sorry for that. We try to land a little lower on the annulus side to avoid any obstruction of the coronaries or interacting with the STJ segment. And this is our inflation here, rapid pacing. And I think we landed in a pretty good zone here below the calcium and the STJ, and also below the coronaries. So we confirmed that our valve looks good. We're happy with the flow. There's no aortic complications that we can see. So we decided that that's it. We don't need any more post-dilations. Now, the most second important step is actually the closure of the aortic hole, and this is what is a little bit scary if we didn't do it right. So we start by reversing the heparin. We give protamine to make sure we reverse the heparin. We have our endograft ready in case of any disaster, and then we usually occlude using the Amplatzer or Dr. Occluder, class 1. We started initially by the double discs, ADOs, and sometimes even VSD occluders, but we found that the ADO plus 1 is usually just sufficient to close the hole. What we do is we actually put a deflector catheter. It's called the Agilis catheter. And the reason we do this is we want to make sure as we are deploying our Amplatzer into the aorta that we are horizontal rather than oblique, as we can see in this picture. So once we come back all the way to the hole, we push our Agilis catheter up and deflect it so it is horizontal, as we can see in the second picture here. And then we release our ADO, take pictures in the IVC, make sure that we're okay. Sometimes the Amplatzer device will go all the way to the IVC or even staying just in the track, which is fine. And then we take a picture in the aorta and make sure there's no significant extravasation. Here we can see a little bit of extravasation around the device, which is actually fine. These are the patterns of fistulas we can see after occluding the aorta. So it can be a complete occlusion, which is perfect, but it doesn't happen so often. or we can have a little bit of a patent fistula. We can have a patent fistula in between the aorta and the IVC, which also is not very common. The most common form is form C, which is a cruciform contrast flow, where you will find a little bit of a fistula with some contrast around it, which is also completely fine. It usually closes off within a day or two, and we always get a CT scan in 30 days to make sure it's completely sealed. The type D is the extravasation, as we can see between the aorta and the IVC, significant flow. That is not good, and this needs some sort of intervention. And usually we just put an endovascular graft from the contralateral side. So actually our patient did pretty well. She was discharged home next day and did well over long term after that. So just in summary, transcaval is a feasible large bore axis. We actually use it a lot of time also in impellas for mechanical circulatory support in patients who have peripheral arterial disease and no good access otherwise. It's very important to select our patients carefully and make sure you have a good proximity between the IVC and the aorta so you can cross without having to go a lot of distance in between the retroperitoneum. Know your anatomy, know your equipment pretty well. Always be ready for disasters, especially when you're dealing with the aorta. And then the last thing is actually, the field of structural heart is still in its infancy. We have a lot of ongoing trials and devices. These are the mitral devices that we examining these days in trials, and a lot of aortic devices as well. So with that, I will end, and I'll be happy to take any questions. And thanks again for the invitation.
Well done, Marwan. It was a very interesting case, حقيقي, and you have courage to go through the aorta into the vein. As you said, you should be prepared. And Dr. May is sitting beside me. I think she has a comment too on this.
First of all, welcome, Marwan. Excellent talk. Thank you very much. I don't know if you can see us or not.
Hello, did I lose you?
Can you hear us? Hello? Marwan?
So what is the long-term outcome for transcaval TAVR?
So, this is a great question. So far, there's about 400 cases that was reported on a paper from Adam Greenbaum, I think about 2 years ago. And actually, this patient did very well up until 30-day outcome, six-month outcome as well. I don't think we have longer term than that in this population, unfortunately.
Can you hear us out there, or Marwan? أشرف تقريبا مش سامعيننا هناك. وائل سمعنا وائل؟ لا بتقريبا هم مع نفسهم، يعني وائل مع مروان. هاي حد شايفنا؟ مروان؟
Yes, I can see you, Dr.
Now you can see me, okay. Can you hear me?
I do, yes.
You can hear me. Excellent talk. Hi, Wa'il.
I think the internet connection is a little slow, but I can hear you well.
You can hear us well. An excellent talk. Just a question. Do you use this only when you have a difficult anatomy, or do you want to do this as a routine in TAVR patients?
No, yeah, we do it only in those who have significant peripheral arterial disease. Our go-to axis is transfemoral. The next one is carotid. Auxiliary, we try to avoid auxiliary as much as we can. It has a little bit of increased risk of strokes compared to carotids and transfemorals. So our order of axis is transfemoral, carotids, transcaval, and then auxiliary.
How many cases have you done transcaval? How many cases
I'm sorry?
How many cases have you done transcaval?
I myself have done 4 over the last year. Here in the US, I think the last report was about 2 years ago, and it was 400 cases.
And what?
Yeah, and the mortality at 1 year was 20%. So the mortality, they reported the one year mortality was 20%. That's why people but all of them are very high risk patients. Absolutely. And that's why there is a new tendency right now to repair the vascular entry first, if we can. And that's why people are using newer technologies for vascular anatomy, and then go from the transfemoral.
Yeah, I was just going to ask about the incidence of...
last time, so just state a lot.
That's true.
What is the incidence
Yeah.
of retroperitoneal hematomas or leakage?
I'm sorry, I didn't hear that. I'm
In
sorry.
how many cases did you have to surgically interfere to for extravasation?
Oh, we had one case out of the four, and it wasn't because we weren't sure if the leakage around the ADO is significant enough that it will seal. The patient was completely hemodynamically stable. There wasn't really a significant extravasation, but we weren't sure that it will seal. Every time we actually waited in the OR for about 30 minutes, and every time we take an injection, there's still some extravasation, which usually should get less over 30 minutes or so. So we just did it, I wouldn't say prophylactically, but it was more of a preventive measure to avoid complications. So, but all of the four cases were pretty stable hemodynamically.
That was a great illustration of a very tough case, Marwan. Congratulations, and we are all here very proud of your achievement. May I ask you if the transcable in your priorities of choosing the axis when you don't have a transfemoral feasible TAVI, so you go for the transcarotid, then the transaxial, axillary or subclavian, and then you go for the transcable axis, or you choose the transapical axis first?
So we don't do transapicals anymore here. We try to stay always percutaneously. We actually go transfemoral, transcarotid, transcaval, and transaxillary. This is the order we try to choose. And as Dr. Weil said, we actually now, after having the shockwave lithotripsy for the peripheral vascular disease, we're able to do a lot of our cases that we weren't able to do initially transfemorally. We're able to do it right now transfemorally by using shockwave lithotripsy.
Perfect. Thanks, Marwan.
Thank you so much.
Thanks for
Congratulations, I'm really proud of you there.
Thank you.
You made us very proud, ya Marwan, as usual.
Thank you so much, guys. I appreciate it.
So now we are moving to the next presentation presented by Pablo Avanzas, Isaac Pascual. He's presenting a live in a box mitral clip in acute mitral regurgitation. I think we have been discussing that issue yesterday, Isaac. We had a very interesting question about managing acute post-myocardial infarction mitral regurgitation, and you told us we're having an interesting case today. So we are all ears for you to share your case with us. Thank you.
Hello, good morning. Can you hear me properly?
Yes, we can.
Hello?
Yes?
Yeah? Okay. I can't share my screen. I don't know why. I don't know why I can't share my screen. No. Okay. I think now it's working. Okay. Sorry. Okay. Okay. Can you see my screen? So, can you see my screen, please?
Yes, you're good. You're good.
Is it working? Okay.
Yes,
thank you
yes,
very
we
much.
can see you clearly. Thank you.
Okay, thank you very much. So thanks, first of all, thanks for the invitation. As you commented yesterday during the live case, we were talking about this topic, and it's my pleasure to share with all of you this live box case in order to summarize the practical role of mitral clip in acute severe mitral regurgitation. So this is the clinical presentation. She was a 64-year-old lady with diabetes, hypertension, obesity, and dyslipidemia, with 2 days of continuous chest pain presentation and progressive dyspnea during the last hour. she was with a hemodynamic profile with hypotension, pulmonary edema, and with a complete AV block with inferior necrosis and persistent ST elevation. This is the X-ray. Because of the hemodynamic profile and the presentation of an established inferior infarction, we perform an emergency PCI. So this is the current angiography, and we plan to drug limited stents with a good result. But the evolution was with persistent heart failure during the next hour. So we perform a TE. The images that you can see, we can see a severe functional and acute mitral regurgitation because of restriction fundamentally of the posterior leaflet. As you can see here in more detail, we can see the restriction of the view here in the transgastric view, we can see that the origin of the mitral regurg is it is in all the coaptation plane with a severe impairment in the pulmonary vein flow. And as you can see here in the 3D detail, we have a severe restriction here in the segment of P2 and P3 scallops of the valve, with the typical pseudoprolapse of A2 compensating the restriction of the posterior leaflet. So with this situation, it was the pressure trace with the aortic and the severe impairment in the left atrial pressure with a severe V wave. And we decided for sure to implant a mitral clip in this scenario. This is an XT1, mitral clip. Here you can see the grasping plane with the grippers down in this position, closing the clip, with a very good cut of the leaflets, the typical movement of the grippers jumping, and we close the clip. And this is the initial result. With here, you can see the reduction in the severity of the mitral regurg with residual MR that we were talking about later on. And here you can see the first clip implanted in the A2, P2 segment, just a little bit medial than more septal than lateral. Here you can see the 3D color, and this is the reduction in the left atrial pressure that we obtained. This is the residual MR that we achieved. So in this scenario, we decided to try to improve the result, and we decided to implant a second clip. This was NT1, a small clip, and more septal in this place, more septal than the previous one, more medial. And this is the result after implanting the second clip. And this is the 3D with the second clip implanted. So here you can see the steeping of the valve in between the A2 and A3 and P2 and P3. This is the trace of the pulmonary vein flow, and this is the final trace in the pressure of the left atrial pressure. Here you can see the step-by-step decision taken that we done with the initial severe MAR, with the initial pressure of the left atrial pressure with that huge V wave. then you can see the result after the first clip with the improvement in not only the color but also in the pressures. And this is the result after the second clip with the final result that we achieved. The final result after the two-clip implantation. The follow-up of this patient was very satisfactory with a clinical improvement, and we were able to discharge the patient after 10 days. But moreover, I want to point out the result after 6 months of follow-up in the transthoracic echo with a very good result with residual MR very small. So I want to talk about the paper that we were talking yesterday about in the live case. This is a recently published paper in the European Heart Journal. This is we have been included in this registry. So in this registry, several patients with acute MR during the 90 days after acute myocardial infarction, patients were evaluated if they receive conservative treatment or interventional treatment, and then the interventional treatment was split in surgical treatment or percutaneous mitral repair treatment. A patient with papillary muscular rupture were excluded. So only patients with acute restriction of posterior leaflet, like our patient, or rapid remodeling annulus dilatation. So the first survival curve shows a significant difference between the intervention versus the conservative treatment. So these patients did better if they were in this arm. But I want to point out this curve, the one of where the treatments in the interventional treatment were splitted. So you can see here the mortality with in blue with surgical treatment and the mortality with percutaneous treatment. So we have better results with percutaneous treatment in these very ill and many times shocked patients. And why? Why? Because if we take into account the in-hospitality deaths, if we exclude the in-hospitality deaths, we have no difference. So these patients died during the hospital stay, and the percutaneous repair can change this natural history. These patients, as every one of you know, are very, very ill in a deep vicious cycle. They cannot be they can't receive the surgical treatment because of the high risk of the patients, so many times they die during the intraoperative procedures, and percutaneous repair can change this natural history. So let me just 1 minute to share with you my take-home messages regarding this case and these reflections. Transgender mitral valve repair with mitral is a safe and effective solution for acute severe post-myocardial functional MR, and the early intervention may need therapy in patients with mitral regurgitation. But moreover, I want to point out the specific role of mitral in this patient. Please don't wait to treat these patients, because mitral is very safe and effective and can change the natural history of this patient. Thanks again for this invitation, and that's all. Thank you very much.
Thank you, Isaac. It was a nice talk introducing the use of mitral valve clip. And now we'll go to, if there's any questions? Any questions from the floor on this subject? Dr. Ahmed Saeed, please.
Thanks, Isaac, for the challenging case presentation. May I ask you, you have been tackling the timing of intervention, and you mentioned that early intervention can improve the prognosis of patients. So how early would you intervene upon this critical category of patients?
As earlier as you can, because when the mitral regurg is established, it's not going to improve. So the patient is in an unstable situation. So if you wait, the patient is going to go deeper and deeper. So I really like to intervene as early as we can.
So in this case, you did it with the PCI? You did the PCI and the mitral clip in the same time, or?
No. We did the PCI, and the patient the next day didn't go well, and then we decided to intervene the mitral. I can't remember the 2 days before the.
But you can do them in the same time, yes? Or?
Sorry, no. Only we have done cases with at the same time PCI and mitral clip, but for planned procedures, patients with chronic heart failure or with chronic FMR that need revascularization, but not in acute patients yet.
Thank you.
Thank you, Isaac, for this great case. I would like to ask you about which patient do you prefer to do mitral clip and which
she reported him left arm numbness. So he repeated an MRI and he saw right middle lobe cerebral artery occlusion as well as multiple old infarcts in the frontal and temporal lobes. And he thought this is a PFO, and he said it's for us to close the PFO. So, and this is the contrast study. You see that this you can see that the septum is really intact here, and on delayed imaging at about 4 or 5 seconds, there's a huge positive bubble study, and this did not attract the attention of the patient, of the person reading the echo, and it was called just a positive bubble study, possible PFO. So, because of the inability to do the TEE, we did a right heart cath with an intracardiac echo, and we see here that we attempted to do, through ICE, we attempted to negotiate, this is the wire and the intra-atrial septum, we attempted to negotiate the intra-atrial septum with the wire just to make sure we don't have any PFOs, and then we did a positive bubble study, and the bubble study was positive while we have an intact septum, and this is with a diagnostic for pulmonary AVM. And if you see here also, you see that the bubble coming out of the left upper pulmonary vein. So we did an angiogram with the patient, and you see we did an initial EP and angiogram, and you see that we have to do an occlusive angiogram for these patients to visualize it very well. So we did a pulmonary wedge catheter. We usually use an 88 French system, and we just put a pulmonary wedge catheter in the left pulmonary artery, and we injected, and you see that this is the feeding artery for the pulmonary AVM. And that's an important to size that artery, because that's how we're going to size your device, and decide even if you're going to go surgically or percutaneously. And we also need to get another image in the lateral view to see the relationship to the origins of the branches of the left pulmonary artery. Then you have to selectively go into that feeding vessel. So to do that, we use usually a Willy wire with the support of a multi-purpose 8 French catheter all the way into that artery, and then we advance the multi-purpose catheter, remove the Willy wire, and then we inject contrast to just document the pulmonary AV fistula. And then the other thing is that we need to see here is how many feeding vessels and how many draining vessels, because that's a key element for us. You see, it's only one feeding vessel and one draining vessel. But if you have multiple feeding vessels, this is not a good percutaneous candidate. Must be better be surgical candidate. Then we advance the vascular block, and we see that we advance both the advanced block both in the anterior and the posterior view. We make sure that the blood goes without any air in it. And here you unsheath the device. So you don't advance the device beyond the tip of the multi-purpose. So what you need to do is to put the vascular block, which you size usually at 1.4 the size of the feeding vessels. So, and you unsheath the vascular block, you don't push it in because the AVM itself is friable. So you want to put it in the feeding vessel. And then you make sure that your delivery system and the sheath, as well as the multi-purpose and the vascular block, are all in good orientation with each other. You don't want any angulation. Then you confirm that you have near complete occlusion of the AVM, and you don't see any flow into the returning draining vessel. And that's in the after we need to continue into the venous phase. So here we already finished into the arterial, into the venous phase, and you see that there is no flow, and already the pulmonary arteries is completely empty. And then you disconnect your coil, and this is how it looks. There you have the vascular block and the coil before it. So pulmonary AVMs in general are very rare lesions. Their prevalence in the general population is very rare, 1 in 20,000. 75% of AVMs are associated with Ehlers-Danlos syndrome, and they are twice common in women and usually present in the 4th to 6th decades of life, which is exactly what our patient was. There is also, particularly in the third world country, there is other etiologies of pulmonary AVMs, particularly in Egypt, schistosomiasis and actinomycosis and TP, which could be on the top of the etiology of pulmonary AVM, not Osler-Brand-Weber syndrome. You also can have it in patients with mitral stenosis, metastatic thyroid cancer, hepatopulmonary syndrome, pulmonary hypertension, bronchiectasis, and pulmonary venatresia. They are classified into simple when you have only one single feeding vessel, which usually represent 80% of the cases, and they are the easiest to manage. And usually percutaneous approach is the best for them, making sure that you don't have if the feeding vessel is more than 8 millimeters, you should not do it percutaneously because they will recanalize again. The incidence of recanalization if the vessel above 8 millimeters is very high. Complex if they have more than one feeding vessel or more than one draining vessel. We have one case that we have multiple draining vessels and multiple feeding vessels, and it keeps recanalizing, and the surgeons even refuse to take her. The main and only treatment for AVM was only surgical excision, which is a big surgery. Usually it has a 5% mortality. So that's why percutaneous right now is really the best option. Thank you. Any questions?
Thank you, Wael. Can you hear us?
Yes, I can hear.
Thank you very much for this challenging case. We had one case with two large pulmonary AVMs, both in the right and left pulmonary arteries, and it turned out to be, and the patient actually presentation was in hemoptysis. We closed them both with very large, one with a VSD device, one with an A device, and he turned out to have a Behçet syndrome. So this is now the etiology for you. So Behçet can cause pulmonary AVMs, and for me it was the first time to see it as an etiology with pulmonary AVMs, and his main presentation, he was diagnosed before as Behçet, and he came presenting with hemoptysis, with two very large, one in the right lung, one in the left lung, and we could close them both, but with very large device, one with an ASD device, and the other one with a VSD device, off-label use.
VSD device?
Yeah, they're huge.
And did it stay completely occluded afterward?
Yeah, we have him on 4 years follow-up now. Completely.
Oh, excellent.
Yeah. But this, it was very strange for me. So this is another etiology.
And did you close it from both sides, from the venous and the arterial side at the same time?
No, only from the arterial end. I did not close the venous end.
And did you have one feeding vessel or multiple feeding vessels?
One feeding vessel probably. One of them actually.
We had one large patient like this, and we closed both sides. So we went transeptal to the pulmonary vein, and we went back into the pulmonary vein and closed that device.
Yeah, that's very. We did that in a patient who had a direct fistula between the pulmonary artery and the left atrium. And we have 2 or 3 cases here, about 3 cases where we have right pulmonary artery to left atrium direct. So these cases were closed.
Rare. This is a rare variant.
We closed them with an ASD from the left atrium. I mean, we went transeptal also because we had to have a loop, so we could stabilize our device between the pulmonary artery and the left atrium. But they are challenging, especially congratulations on being able to cannulate the feeding vessel, because this is always the challenge and always the difficult part of the procedure.
Yeah. We fortunately enough we have biplane. I'm not sure, so and I think it helps. Yeah, it's really difficult, but with PCI techniques you can cannulate anything.
Yes, excellent work. Excellent.
Well, you did a great job. You made it look easy, though it's not. As Dr. May said, cannulating the feeding vessel is difficult. I think you made use of your expertise as an adult cardiologist and used the equipment provided in the cath lab. My question to you is, what's your preferred order of using cases? Would it be easier to anchor a vascular block with a flipper coil rather than putting the vascular block followed by the flipper coil? Would this order of using, or you don't have a routine in this, you just tailor it to each case?
You need the vascular block first, because if you put the flipper coil before, it may, and you have a high flow into that EVM, the coil, you may need more coils than you need, and you will have and the coil may not occlude. But if you get the vascular block at least will maintain 80 to 90% occlusion first and decrease the flow first, and then you can control that flow more with the coil after. So, that's why you need the bigger device first, and then you can complete that with the coil after.
Okay, thank you. Thank you, Dr. Wael, very much. It was a pleasure having you here. And with this, we wrap up the session. To go to there is the symposium and then a live transmission, followed by live transmission. Thank you very much.